I'm not sure how many of you are aware, but the CDC claims they are prepared for anything, even a zombie apocalypse. So, I would like to see a show of hands of people that know that the CDC actually has a zombie preparedness website. There's quite a few. Okay, raise your hand if you think the CDC was ready for Morgellons disease. I don't see any hands. Anyway, today I'm going to be discussing the CDC's Morgellons study, and it was called Clinical, Epidemiological, and Molecular Features of an Unexplained Dermopathy. And we'll take a look at just how well prepared they were. Yeah, is it this little one here? The silver one? Okay. I clicked on it and nothing happened. Just that one?
That's right.
Oh, okay. Okay, thanks. This is my disclosure statement, and I do not have any conflicts of interest to declare. And I'm not sure if anybody's doing CME credits, but these are the presentation objectives. So if you can just take a brief look at those. Morgellons disease is a dermatologic condition associated with Lyme disease. It's characterized by spontaneously appearing, slowly healing, ulcerative skin lesions, and these lesions contain colored filaments. They're mostly white, blue, and red, and these filaments protrude from or are embedded in skin. Patients may also have stinging or crawling sensations. So I want you to take a look at the lower image. You can see that the light's not, there's a little bit too much light in this room to really see, but there's fibers that are embedded underneath unbroken skin, and some of these are very, very fine, and they're branching, and they are arranged in a very elaborate manner. Well, patients, even with microsurgical capabilities, are not capable of implanting fibers in such a configuration. And on the upper image, we have a callus on a Morgellons lesion, and you can see a fiber embedded under that callus of skin. So, Morgellons is a polemic topic, and the proponents of Morgellons, of which I am one, believe that it's a true somatic illness, that it has an infectious etiology, and the image on the left-hand side shows a nice spirochete that I photographed. And we maintain that the filaments are biological and that they are the key diagnostic feature of this dermopathy. Opponents maintain that it's psychogenic in origin, that it's a delusional condition, and that these fibers are either accidental contaminants or self-implanted textile fibers, and they believe that these fibers are not part of the disease process. This is the actual CDC study, and as you know, I've mentioned the title, so I won't repeat that. I'm going to, from here on out, just call this paper the CDC study. It's published and it's available online, and it was published in the Public Library of Science. 1. Note that there are 15 authors in the study. This study took 4 years to complete, and it cost over $600,000 of taxpayer money. This is just a little bit of a history of the CDC's involvement with Morgellons. In 2006, the Centers for Disease Control and Prevention, or the CDC, they were contacted about Morgellons. In January 2008, the CDC partnered with Kaiser Permanente Northern California and the Armed Forces Institute of Pathology to investigate Morgellons disease. And they called themselves the Unexplained Dermopathy Study Team. For convenience, I'm going to refer to Kaiser Permanente Northern California as either Kaiser or KP. The study team invited an external peer review to independently review their raw data, and it's important to know that it was their raw data that they evaluated. The external peer review did not have access to the finished paper. So on September 24, 2009, the report of the external peer review was published. There were 6 panel members, including Dr. Randy Wymore, who's here today, and he has also spoken about the shortcomings of this study. On January 25, 2012, the CDC published their long-awaited study. And since that time, newer studies have refuted the CDC studies, but the CDC has no plans to further investigate. So, let's take a look first of all at the competing interest statement. Did they have competing interests? It claims not. One or more of the authors are employed by a commercial not-for-profit entity, Kaiser Permanente. This does not alter the author's adherence to all the Public Library of Science 1 policies on sharing data and materials. I believe what they're trying to say is that they have no conflicts of interest to declare. However, they admit that some of the authors may have worked for a not-for-profit entity, Kaiser Permanente. But Kaiser Permanente is a consortium of both for-profit and not-for-profit entities, and it is the largest managed care organization in the United States. Their revenues in 2015 were $60.7 billion. Wouldn't we have liked some of that money to go to Morgellons research? And the net income was $1.9 billion. The for-profit entities fund the not-for-profit entities, and therefore they influence them. So, Kaiser has historically prioritized profit over patient welfare. And here are a couple of examples. One, in California, Kaiser was fined $4 million for not providing adequate mental health care to their plan holders. Prior to this study, Kaiser Permanente had been diagnosing all the people that were identified as Morgellons patients with mental illness, with delusions of parasitosis. And mental illness is a diagnosis they seem to have had little empathy for. 2, the city of Los Angeles filed both civil and criminal charges against Kaiser for patient dumping. And when patients couldn't afford medical care, they dumped them out on the streets. The image you see on the right is a surveillance photo of a 63-year-old homeless woman in her Kaiser Permanente hospital gown and booties. She was delivered to Skid Row, Los Angeles. And 3, Kaiser introduced an in-house kidney transplant program. They saved money and they had an unheard of 100% success rate. But patients who needed a kidney were far less likely to get one. In 2005, they performed 56 transplants, but twice that many people died while waiting for a kidney. So, now let's look at the conflicts of interest for the CDC. As we saw before, there were none disclosed. The CDC study acknowledged that there was an association between Lyme disease and Morgellons disease, and this was in their introduction. But as we know, Lyme disease is controversial, and both the Centers for Disease Control and the Infectious Disease Society of America have a narrow case definition and very restrictive guidelines for Lyme disease. The CDC has had a history of underreporting Lyme disease cases. In 2013, the CDC statistics indicated that there were only about 30,000 cases of Lyme disease reported yearly. But then later on, they admitted that the figures were actually much higher, and they estimated that perhaps as many as 300,000 people were actually diagnosed with Lyme disease each year. The truth of the matter is that the CDC has no clue about how many people have Lyme disease or how widespread it is. And this is true in part because the CDC's recommended test protocol really doesn't work very well. So, even some of the CDC scientists have doubts about their objectivity and reliability. A group of CDC scientists calling themselves Scientists Preserving Integrity, Diligence, and Ethics in Research, or CDC SPIDER, presented a list of complaints to the CDC Chief of Staff and provided a copy to the public watchdog organization U.S. Right to Know. And here are some quotes. "We are a group of scientists at the CDC that are very concerned about the current state of ethics at our agency. It appears that our mission is being influenced and shaped by outside parties and rogue interests. What concerns us most is that this is becoming the norm and not the rare exception. These questionable and unethical practices threaten to undermine our credibility and reputation as a trusted leader in public health." Any study begins with a peer review. So, when we look a little bit into the peer-reviewed literature that the CDC study had, peer-reviewed literature had provided a case definition, and they suggested possible etiologies. The paper by Savely and Stricker, 2010, was cited in the CDC study, and it used a case definition that required the presence of thread-like fibers of varying colors in lesions and intact skin, and it made an association with Lyme disease. Middleveen and Stricker, 2011, was published prior to the CDC study, but it was totally ignored. It emphasized that dermal filaments were the key diagnostic feature of Morgellons disease, and it compared Morgellons disease to a spirochetal infection in cattle, which provided clues about a potential spirochetal etiology. So when we look in the CDC study, it states that there was no established diagnostic criteria accepted by the medical community. Therefore, they did not have a definitive and appropriate case definition. They said that they therefore had to rely on self-diagnosed cases. The CDC study admits that literature suggested an association with Lyme disease, but then they failed to subsequently adequately act upon this important possibility. So, the case definition. The case definition that they used was any person who was a member of and received care at Kaiser Permanente, Northern California for any period between July 1st, 2006 and June 30th, 2008, the case finding period, and this is important, reported fibers, threads, specks, dots, fuzzballs, granules, and other forms of solid material coming out of his, her skin, and one or both of the following: a skin lesion such as a rash, wound, ulcer, or nodule, or a disturbing skin symptom such as pruritus, the feeling that something is crawling on top or under the skin, or stinging, biting, or a pins and needles sensation. So when you look at that case definition, you realize the patient did not have to have any dermal filaments or anything at all coming out of the skin. So the problems with this case definition are, 1, dermal filaments were not required, and they admit that they didn't find any subjects who actually had any. 2, they selected subjects who thought they had fibers and other solid materials, not subjects who actually had anything or who had dermal filaments. Dermopathy or abnormal skin was not required. A subject could have completely normal skin, providing there was an unusual sensation such as itching. So I, for one, would like to know how you can study a dermopathy if there isn't one present. They gave the external peer review a case definition that required dermal fibers, but then they changed it when they said they couldn't find any. And furthermore, when you look in the report of the external peer reviewers, they were told that fibers should be present in normal skin. But published literature from the proponent point of view indicated that fibers could be found under unbroken skin, but it did not indicate that fibers were found in normal skin. So, the lack of a definitive and appropriate case definition negatively impacted their entire study. So, the case definition was flawed, therefore selection was flawed. Dermal filaments weren't required, so lesions with dermal filaments were not identified. There were no primary lesions reported at all. The eligibility requirements were very restrictive. Subjects had to speak English, had to be greater than or equal to 13 years of age, had to have a symptom within 2 weeks, had to be enrolled in a Kaiser healthcare plan. And exclusion of subjects without a Kaiser plan was particularly important. It not only eliminated people who were insured elsewhere, but it eliminated all uninsured people. So, as we know, the Affordable Health Care Act came into effect after subject selection was finished, and many patients with Morgellons disease are disabled and limited in their ability to work, so a health care plan may have been unaffordable to many, and many might have had pre-existing health conditions that were exclusionary for them. So Kaiser searched their electronic health records for keywords such as fuzzball and the like, but they also searched for the word delusion and the diagnostic code 300.29, which is the code for delusional parasitosis. This meant that they had a selection bias for subjects with real delusional mental illness. They were offered help selecting participants with documented dermal filaments by the Charles E. Holman Foundation and by physicians who had such patients, but they declined any help. They therefore ended up with a heterogeneous group of patients that may not have contained any true cases of Morgellons disease, but that very likely did contain true cases of delusional parasitosis or other delusional mental illness. Once selected, the subject numbers diminished as the study progressed, especially at the end of the study when the search for pathogens and fiber analysis occurred. And you can see it plummeting in that graph where we go from quite a few down to like zilch. Of the 467 identified, 50.5% did not meet the review criteria. Why? Any information about disqualification was lacking. It was not provided. Then they reported that no fatalities ever resulted from this disorder, and yet, if you look in there, you can see that 2 subjects died, and the cause of death was not provided. This might have been relevant. We don't know. Of the 218 who met the review criteria, 52.7% did not meet the case definition. Again, why? They didn't disclose why they were eliminated. Kaiser enrollees who contacted Kaiser were invited to participate. So they said, but what happened to them? Where did they go? They seem to disappear in the flow chart. 70 completed the survey, 41 completed clinical evaluations, 36 completed neurocognitive neuropsychiatric tests, 30 were biopsied, 28 were cultured, and 12 had fibers collected from them. Remember that there were 15 authors, and yet only 12 patients had fibers collected from them for study. So, why did these subjects leave? One, Kaiser had a reputation for treating Morgellons disease patients very badly, and some of these subjects reported to Dr. Wymore that the survey was very long and leading. Then, the clinical exam required a humiliating whole body photography. So if you only had lesions on your arm, you still had to have your whole body photographed all over. The neurocognitive tests may have been tiring and/or intrusive as well. And lastly, the physical examinations were conducted at Kaiser's Division of Research in Oakland, California. So if you had any travel constraints, too bad. And this may have really affected people that had disabilities or income limitations. So, let's take a look at their section entitled Prevalence Estimates, Geospatial Mapping, and Epidemiological Factors. Note that the word epidemiological is emphasized in this entire report. And yet, selection factors such as the exclusion criteria and the fact that their electronic health records were not complete at the time of the study may have slanted these statistics. The study reported the prevalence to be rare, 3.6 over 100,000. But again, the selection process influenced the accuracy of this figure. There was a higher rate reported in females than males, but then they admitted that females were more likely to fill out the survey than men. So that figure isn't even accurate. Then they reported that 78% had exposure to solvents. Well, what does that mean? Was it somebody who just used a little bit of fingernail polish remover, or was it somebody who was sniffing glue in a towel? We don't know. Is that figure higher than that of the general population? They also reported that drugs were detected in 50%, but again, the details and the relevance were not explained. Is that consistent with the general population? Was the use occasional, or were some of these people addicts? If they were addicts, some of these patients or participants may have had drug-related delusions rather than true Morgellons. So, now for neurological and psychiatric findings. 60% had cognitive impairment not explained by a deficit in IQ. 59% had impairment in at least one domain, for example, attention and memory. 63% had somatic complaints elevated to levels rarely documented among other clinical studies. Many subjects had functional impairment exceeding that seen in the general population, and this was described as being comparable to that seen in people with serious medical disorders and concurrent psychiatric disorders. 50% had poor quality of life, statistically higher than that reported in California or nationally. So don't you think that all of that should have suggested to the authors that there was evidence of a disease with a neurological component? It's important to note that Lyme disease can cause various neurological and neuropsychiatric symptoms. So, clinical findings. Multiple organ symptoms were reported by 50%. Fatigue and musculoskeletal complaints by 70 to 71%. 15 had elevations of nonspecific inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate. 10% had positive antinuclear antibodies, evidence of inflammatory disease or autoimmune disorders. Many subjects therefore had objective clinical evidence consistent with the disease process. These same findings are commonly reported in patients with Lyme disease. In addition, the study did not include testings for cytokine levels, and they cited a study by Harvey et al. In which they reported an association between cytokine elevation and Morgellons disease. So why didn't they repeat this testing? I don't know. In addition, there's no indication where or what lab performed these routine tests. So now we have skin lesions. They biopsied both normal and abnormal skin. But remember from before, abnormal was defined as having an abnormal appearance or an abnormal sensation. So abnormal skin may have in fact been normal. They found a wide variety of lesions that could not be explained by a single disorder. This suggests that they found a heterogeneous group with unrelated illnesses. 40% had histopathologic abnormalities consistent with rubbing or excoriation. I'd like to point out that the itching and discomfort that is described by Morgellons patients is extreme, and many patients admit they pick and scratch, so this could be expected. Some of these subjects had evidence of secondary infection, and secondary infection of open lesions could be expected as well. The lesions were described to be mostly on the posterior surface of the arms and back, sparing of a dumbbell-shaped area in the center. These facts were meant to emphasize self-infliction or self-mutilation. However, other people who have studied Morgellons have reported that some of these lesions are in places where patients cannot reach. And the posterior arm, I would like to point out, has more follicles than the interior of the arm. Morgellons can be associated with folliculitis, and folliculitis was noted in the CDC study. The most common abnormality was solar elastosis, and this was found both in abnormal and normal sites. And I think this finding could be expected in California where people are exposed to sunlight. And I have seen some patients with Morgellons lesions that have formed in area where there's damage to the skin, such as sunburned areas. So now we're on to fibers. Morgellons filaments originate within human skin and are found in calluses that may detach, leaving an ulcerative lesion. At 50x magnification, you can see the fibers projecting from or embedded in skin. And to avoid studying environmental contaminants, it's essential to collect dermal filaments that are projecting from or are embedded in skin. Some of the problems of the CDC study were, one, they used a dermatoscope for examination, but they did not provide any magnification. So we don't know at what magnification they were looking at these things. Standard dermatoscopes are usually 10 times magnification, and that is insufficient to see these fibers. Two, they collected an array of materials of different colors, which suggests they collected environmental contaminants. Three, they said that fibers were found in superficial crust, and they admitted that these may have been introduced at the time of their collection and processing. So, in other words, the doctors themselves implanted those fibers and then blamed the patients for being delusional for having them. 4. Birefringent material consistent with cellulose was detected in 16 of the biopsied lesions, and the analyzed fibers were predominantly cellulose consistent with cotton. So, they did not identify lesions with dermal filaments, so therefore they did not collect any Morgellons fibers. They collected the wrong cohort and the wrong specimens. So are any of us surprised that the results are so dismal? So now we'll go on to detecting infections. Lyme disease was acknowledged as a possible etiology in their introduction. And Lyme disease is caused by infection with Borrelia burgdorferi or closely related Borrelia species. And infections can be detected either by looking directly detecting the pathogen in the patient's tissue or fluids, and examples of these are microscopy and DNA detection. Or you can look for pathogens indirectly, and this would be by detecting the patient's immune response to a pathogen. And examples of these are tests that detect an antibody response. I would like to point out that absolutely no direct detection methods to specifically detect Borrelia were done in this study. The search for Lyme disease or related Borrelia species was limited to a single flawed serologic test. And if you look on my images, on the upper left and the bottom, those are spirochetes from Morgellons patients, and they were detected in our studies. The top is from a culture, and the bottom is a stained spirochete in tissue. Borrelia spirochetes are present in Morgellons samples, and if you use the correct detection methods, you can find them. So, although other detection methods for Borrelia infection exist and are useful, the only test that the CDC recommends for Lyme disease is a defective serologic test. So let's look at let's look at the testing that the CDC study did use. They used a test protocol that was intended for surveillance, a two-tiered test. The test that they used was a commercially available screening enzyme immunoassay, or EIA, followed by confirmatory Western blots. This test protocol has a specificity that is estimated to be about 99%, which means that it can cause very few false positives, but its sensitivity is estimated to be between 29% and 68%, which means a lot of false negatives. So when you look at those numbers, the chances of you getting an accurate test result is like a coin toss. They used a lab strain, B31, as an antigen source, and testing based on B31 alone does not capture the genetic diversity that we find in clinical specimens. Western blots were done only if the immunoassay screening test was positive. But this screening test misses 35% of culture-proven Lyme disease, and Western blots are both more sensitive and more specific than the screening test. They did both IgM and IgG Western blots, but they only considered the IgG valid. And long-term studies of culture-positive Lyme patients has found that prolonged IgM reactivity is common, and yet the CDC chose to ignore that. 5 out of 10 diagnostic bands were required to be interpreted as a positive, And I would like to point out that your body has not read a manual telling it that it needs to produce 5 bands in order to be a positive. Our bodies make what they make, and there's many, many reasons why you can have a weak immune response. And these include things like the antigen sequestration and the fact that there's not many of spirochetes in your circulatory system, and immunosuppression in patients, etc. This also ignores the specificity of the antigen, and some antigens are thought to be very specific for Borrelia and not cross-reactive with other organisms. So therefore, if you have one of those positive bands, it's highly suggestive. This study reported that there was 1 out of 41, which would be 2.4%, was found positive by the screening test. This figure is higher than you would expect in the general population. The CDC's average estimated incident rate for Lyme disease in the United States is 0.0073%, so that figure actually may have been relevant. This is a quote by Paul Mead, who is the Chief of Epidemiology and Surveillance of the CDC Lyme disease program. We know routine surveillance only gives us part of the picture, and that the true number of Lyme cases is much greater. So the CDC is aware that their recommended surveillance program is not sensitive, and that would include their testing. So let's take a peek at what they did look for. They were a bit better when it came to looking for other organisms. Biopsies were stained with a standard histological stain. So it was probably hematoxylin and eosin, and those stains aren't really very good at picking up pathogens. But only those that showed inflammatory infiltrates were sent for additional staining. And Borrelia is an organism that does not always produce a strong inflammatory response. Then further staining was described as lily-twort, which is a type of gram stain. And I would like to point out that gram stains are not suitable for viewing spirochetes, or they used Warthin stari or Grocott methenamine. Both of these are silver nitrate stains, and they will stain Borrelia bacteria, but they also stain other bacteria and artifacts. Borrelia can be pleomorphic, and they may look like other organisms or artifacts, so these stains can be difficult to interpret. So they found 12 specimens that had bacteria and 8 with fungi. Only those with obvious bacteria were sent for further investigation, and this was described as immunostaining and PCR detection of DNA. So the testing confirmed that the bacteria were Streptococcus or Staphylococcus species. So why did they do PCR and sensitive molecular testing for staph and strep, but not for Borrelia? Do you think maybe they didn't want to find any? So on we go to culture. The American Society for Microbiology considers culture to be the gold standard of detection for pathogens, providing a pathogen is culturable. Borrelia burgdorferi and other Borrelia species are culturable. 53 culture swabs or specimens were sent for routine culture from 28 patients. They do not mention anything about culture methodology, and those are factors such as what organisms they selected for, the temperature, the aerobic conditions or limitations, types of media used, etc. Borrelia are very fastidious, and they require very complex growth media, and routine microbiological culture will not allow them to grow. So they took also some biopsies from abnormal skin for culture, but remember, abnormal skin could actually be normal. and they do not indicate where culturing or biopsies took place or if there was any transportation involved. The swabs were transported to Quest Diagnostics for culture, and swabbing and transporting is not suitable for fastidious bacteria. So they also mentioned that they did some urine culture, but again, they didn't describe any of the culture conditions. They said that they cultured for viruses if the lesions looked suggestive, but again, their methodology did not provide any details on that culture. There was absolutely no indication at all anywhere in the study that they did any culture for Borrelia. So here's a little comparison of the CDC study and the research by proponents. One, they did not require dermal filaments to be present, while proponents did. Two, they selected patients by searching their electronic health records for keywords, while in refuting studies, subjects volunteered. Three, they studied loose cellulose fibers, many of which they admitted they implanted, while refuting studies looked only at embedded human biofibers. Four, their search for Borrelia was limited to serology, while in our refuting studies, we directly detected Borrelia species, and we did so by providing visual, antigenic, and genetic identification of Borrelia species both in culture and directly in skin specimens. And in addition, other pathogens have now been detected. Treponema denticola and Helicobacter pylori and Bartonella species have been detected in Morgellons specimens. And five, they concluded that this condition was delusional, while our refuting studies showed that it is an infectious process. So, I cut and pasted the conclusion of the CDC study, and this is a direct quote. This unexplained dermopathy was rare among this population of Northern California residents, but associated with significantly reduced health-related quality of life. No common underlying medical condition or infectious source was identified, similar to more commonly recognized conditions such as delusional infestation. So, not only is the last sentence grammatically incorrect, but how can they say that it's rare or non-infectious when they failed to look properly for it? So, why did this study fail? Well, perhaps it didn't. Maybe it did exactly what it was designed to do, which is nothing. First, there were some undisclosed conflicts of interest. They used the wrong case definition. They had selection bias. They selected the wrong cohort. They disqualified potential subjects without adequate explanation. They dissuaded participation by exhaustive and intimidating surveys and examinations. They totally ignored objective evidence of disease. They selected the wrong specimens. They used wrong or ineffective methods, and therefore they found nothing. So, I don't feel much comfort in knowing that they are prepared for a zombie invasion, because they sure as hell were not prepared for Morgellons disease. The public relies on the CDC to protect us from pandemics, but given that this dermopathy was so grossly mishandled, I have doubts about their ability to do that. And for the people with CME credits, this is a knowledge check. And here's my acknowledgements, and that's thanks to Cindy Casey and the Charles E. Holman Foundation. And again, congratulations on the 10th anniversary, and also for giving information and providing support. Thanks to Virginia Savely and Dr. Wymore for all their work, and to the patients. And I'll quickly show my references, just so you know I actually did some research on this.